Good evening. Today is the 31st of May 2025, and we are a CPD group of AFPI session on clinical assessment tools. We have two eminent, very popular speakers. One is Dr. Hemant Saluja and Dr. Sai Krishna. So the first one would be Dr. Hemant.
Yes, Dr. Hemant, before we start, can we uh, introduce our chairperson, Dr. Maitri? Dr. Maitri, welcome to our session. It's a great pleasure to have you. We felt very great meeting you during our Wonka session and discussing a lot of things.
Thank you, Dr. Bhargava, and thank you, Dr. Vidya, for everybody for giving me the opportunity to be in this August virtual gathering. So we shall today be discussing about the essential clinical scores, uh, which is called the primary toolkit for primary care physicians. I shall be dealing with basically the elderly people, the toolkits that we use for screening diabetics, and clients with mental health challenges. Although it has been my endeavor to cover most of the important scores, but it is not possible to cover everything in the limited time that I was given. So I shall start, and as we know, in family medicine, we do a three-stage. We do a holistic approach, and it involves a three-stage assessment in family medicine. So, and what it does for us is it gives us a. Can you all see it?
Yeah,
Hello?
right.
Yeah. So, what it does is that it creates for us the holistic model, and it helps us deal with the situation in toto rather than looking at a piecemeal approach. And it for that we divide the assessment into three things. One is the clinical assessment. Then comes the or which is called the biomedical assessment, in which we focus on the patient's medical issues, and all the clinical examination is done in this and diagnose, and it helps to manage the disease, identify the disease, and we kind of approach all the histories are taken in this, and protective factors are considered, and relevant physical examination is given. And we also do the opportunistic screening, and health promotion is done in clinical assessment. Then we go on to the individual assessment, in which this is aimed. What we do in this is it helps us understand the patient's motivations, barriers, and his understanding of things, what the patient experiences, and what his perceptions are, his or her perceptions are. So it's just like addressing his ideas, concerns, and expectations, what he had, and the beliefs that he had, understands how the illnesses affects his daily way of life and well-being, So those are the things that we assess in the individual assessment. Then we come to the very important and most neglected part of clinical areas by other subject matter experts. And what we do is here we examine the broader context influencing the health and evaluate the family structure, support systems, the home environment, and we also look at the education and financial status of the person. We identify the social determinants and the stressors that may impact health. So in short, what we do is we kind of identify the factors that may affect the illness management and its outcomes. And what it does for us is, why should we do it? Why should we follow this approach at all? So, because it ensures that a person-centric approach gives us a holistic approach to care. It kind of facilitates the individualized management plans when we are addressing medical, psychological, and social needs. And it, in this process, enhances the patient engagement. So it is a shared decision making. And we become adaptable to different clinical scenarios, and different scenarios in different settings have different resources available at their disposal, and for them to be used. Now, to make the things easier, I have chosen to choose a way in which I shall be discussing a common clinical scenario when which presents to us in practice, and we shall be seeing what all scores we shall be using in assessing that scenario. So the scenario is that Mr. Suresh Kumar comes to you with his son, Mr. Anil Kumar. Is everybody able to see it?
Yes.
Okay.
Yes.
So Mr. Suresh Kumar is 68, a retired railway employee from Kanpur. Presents with, for your information, Kanpur is a big railway city with a railway presence in it. It's a city in Uttar Pradesh in India. Presents with forgetfulness, low mood, anxiety, poor diabetes control, osteoarthritis of the knee, urinary symptoms, and difficulty with daily activities. Now, this is not an uncommon scenario that an elderly gentleman comes to you with all these things. It is probably the commonest thing that you would be seeing in your practices. And he lives with his wife and his son's family. The son, Mr. Anil Kumar, who is 42 years, is concerned about his own risk for diabetes due to his family history and is seeking your advice too. So we have an elderly come with his son, with whose family he lives, with his wife, and he has a variety of associated problems. And this son also has a problem. He has a concern that he's bothered about his own risk of diabetes. So we shall be discussing it in the background, and this is how we shall be going about it. So this 68-year-old gentleman, as we already discussed, has diabetes, hypertension, osteoarthritis, and frequent urination, nocturia, and has low mood, and has increased forgetfulness, and has difficulty with daily activities. Now, this is due to probably because of his lethargy, because of poorly controlled diabetes, because of osteoarthritis, because of low mood. Everything seems to be interrelated, right? So that's what the aim of this discussion is, to see that in such complex situations, how can we actually pick and connect things. Then comes the three-stage assessment that we did. So as we discussed, the clinical assessment is where we assess his symptoms and do the physical examination. We sort his forgetfulness, low mood, and activities of daily living. That's what ADL stands for. And saw that difficulty with ADLs and his urinary symptoms, and we discussed and investigated that in some detail. We saw his BMI was 28, his blood pressure, he's a hypertensive, but his blood pressure is under control. Maybe he's taking medicines are acting, and no focal neurological deficits. Coming to his individual or personal assessment, he has anxiety about memory and diabetes and its complications. That's what he is concerned about. He's demotivated about self-care and is embarrassed by his urinary symptoms to the extent that he has, kind of stopped going out in public functions and with family because it embarrasses him to actually go to the toilet because he cannot he has so much of urgency. And he worries about becoming dependent on the family. This is the individual assessment. Coming to the contextual assessment, he, as shared previously, he lives with his son's family. Family is supportive, but like every other family, every member is busy in his own endeavors. They have limited social activity after the endemic, like in every city, everybody is kind of shattered and new normals have been created, and they avoid outings due to his urinary urgency. Now, what scores did he use to fill? One is this general anxiety score, GAD-7. Now, what is this GAD-7, as you may want to know? So I have this here. Can you see this? Can you see the score here? Or shall I change the settings?
Dr. Hemant, the score 11 is there, but
No,
the
it's a Word document. Can you see
no,
it?
no.
No.
You'll have to change the.
Okay. Okay, just a minute. Okay. Can you see it?
Yes. Okay.
So it's a self-administered questionnaire. It has about 7 items, and we ask the patient to or the client to ask. Now these days the word patient is being replaced by the word client to make it more acceptable. So we ask the client to ask how he or she has been in the past 2 weeks, and ask whether he's feeling nervous and things like that. And if we have to go on discussing these details of all the scores, I think we'll overshoot the time. But for sake of brevity, it just assesses the anxiety level, whether he's been on edge, whether he's overthinking, whether he's hard to sit without doing anything or thinking anything, how's his mood, becomes annoyed or irritable, and he's afraid of something awful might happen. Just we're trying to gauge his or her thoughts and the thought patterns, whether they fit into the framework of the anxiety diagnosis. And how they respond is by these 4 scores: not at all, several days, more in the last 15 days, 2 weeks, right? So more than half the days, nearly every day. Total maximum score is 21. And how do we interpret? 0 to 4 is minimal anxiety, 5 to 9 is mild anxiety, 10 to 14 is moderate anxiety. And now this gentleman has a score of 11 that fits into moderate anxiety. Okay, now interpretation is moderate anxiety. And what happens is then we ask the patient, because he feels his mood is low. So we use a patient health questionnaire 9, which is again a self-administered questionnaire. And where is the Zoom gone suddenly? Can you see the PHQ-9?
No, only the anxiety scores are there.
No.
నేను AFPI మెంబర్ అసోసియేషన్ ఆఫ్ ఫ్యామిలీ ఫిజిషియన్ ఇండియా మెంబర్ లో ఉన్నాం కాబట్టి నేను 150 300 అట్లా ఉంది రిజిస్ట్రేషన్.
I'm sorry.
Hemant, we see the same screen. Score severity, minimal anxiety, mild anxiety, a score of 10 or greater.
Okay, so you see this screen now, PHQ-9?
Yes, right, correct.
So this is how the patient, how we follow up a case of suspected depression or mental health challenge of depression. And the patient in the last is asked about, again, like in the past 2 weeks, how have you been? And it asks about couple of things, not at all, several days, half the days, and nearly every day. Likewise, feeling bad about yourself, poor appetite, feeling tired or having little energy, trouble falling or staying asleep, feeling down or depressed, hopeless, have little interest in pleasure in doing things, and thoughts that you would better be dead or of hurting yourself. So this is a very, very important question that we must ask, because if any answer to any of these to this is yes, then it is a red flag, and it should an instant action of referral should be initiated, because we need to intervene right away, most aggressively. Otherwise, something untoward might happen. So that's how we carry out this PHQ-9, and his score was his score was 15, which is moderate depression, moderately severe depression. And so we noted that. So we noted moderate anxiety, and we noted moderately severe depression. Now, we move on to the other score called the GPCOG score, GPCOG, that is General Practitioner's Cognitive Function. Now, it can be done online. It can be done as an inpatient assessment. It can be done. Depends upon what resources you have. So usually you ask about 4 questions. And can you see this? I'm going to show you. Can you see this? This is the GPCOG score, patient assessment before. So you say it like this, that I'm going to tell you a few names and addresses, and I'll ask you a couple of questions, and then you'll have to repeat whatever 4 things I told you. You ask about his orientation in time, and then you give them a circle and tell them to draw a clock, and then you give them a time that you want to draw, maybe 10 minutes past 11, and then you mark them upon how they draw. And can you tell me what happened in the news? That's about assessing their orientation again. And then you ask about the 4 things, 5 things that you told, and you do not give them more than 4 chances. That is important. It is not just the first chance. You give them 3, 4, 2, 3, 4, but not more than 4 chances, and you wait. And then you score this, whatever their score is, and this gives you a printout. It's very easy. Even apps are available. You do not need internet connection. If you have that, you can even use it without an internet connection. And his score was 3/9. So this interpretation is there's a likely cognitive impairment. Then we move on to because he's a diabetic and he's bothered about his poor controls, even though he's taking medications, but probably because he's not moving because of his circumstances, his knee and his low mood and his energy and his circumstances. So he thinks that, what is this? Is a wonderful questionnaire. It is again self-administered, and I am going to show you this, and this is going to be a game changer for those primary care physicians who think that they want to make a difference in their patients' decision making and follow-ups, because they might say that, yes, I'm walking more, I'm compliant to all these advices that you give, but how do we objectify their compliance? So these scores not only help us to put a number to the subjective feelings, but they also help us to follow it up, that whether there's a objective deterioration or objective improvement in their compliance, and hence we can prevent or anticipate complications. So again, this in the last 8 weeks, we asked that statement, which all statements apply to you, and these take time. So maybe once they are waiting before the consultation, or your subordinate staff can help them fill out this form. Electronic forms are available in all languages, so you can actually download the language that you wish to use, or you can at the same time, depending upon what the comfort level of the patient is with the language you want to use, you can change the language also, but the questions remain the same, and likewise the interpretation remains the same, and the things are likewise applies to me to some extent, to considerable extent. And what the peculiarity about DSMQ is that it has questions about food, about medicine, about compliance, and it has some negatively worded questions which are to be reverse marked. Now, how they are to be reverse marked is if my diabetes care, self-care is poor. Suppose we consider the question, my diabetes self-care is poor, and we say, yes, it applies to me all the time, very much. Then we do not add 3, we subtract 3 from the score. So once you start using it, it has a legend that you must use, and you will become familiar once you start using that. Out of, suppose the maximum score of the 4 of the compliance thing is 10, and the patient gets a score of 4, then you, or a 4.5, then what you do is 4 by 10 into 10. So then you get out a percentage, and then you add up, and then it becomes a value, and then you in the end add up all the values, and it becomes a bigger value. So but it is going to be a game changer once you become familiar with it, because this is the way diabetes is going to be managed in times to come by primary care physicians. Because this not only gives you the power and the patient the power to understand and objectify his achievements, but it also acts as an encouragement for the patient to see, yes, yeah, last visit my DSMQ score was say 15, now it is 20. The higher the score, the better is the control. The higher the score, the better is the compliance. So, and this gentleman's score is 10, so it is kind of compromised. Now he has a urinary problem as well. So what we do? So we get stuck. So we just ask. Otherwise, if it were not for the IPSS International Prostate Screening Score, we would just be asking that how many times you get up, do you have, how is the flow, how is the stream? But when we give this questionnaire of IPSS, you will see how, and once the patient uses it, you will see how brilliantly we can actually categorize, objectify, and see that what is the where does the patient stand in terms of his urinary outflow, lower urinary outflow tract obstruction symptoms. And I'm going to share that IPSS score with you. It is in this thing. Right. Can you see this IPSS?
Not yet.
No. Okay.
Hemant, we know we started late. But,
okay. Okay. Never mind. It's a simple questionnaire in which again we have, and then we have the FRAC score. FRAC score is to assess the 10-year possibility of a fracture, major orthopedic fracture or a hip fracture. Depends upon, it's again, it is to be done by a country specific score, which is an online website tool, and you can do this, and this is how it is going to be. Do you see this? This is for India. Do you see this?
Yep.
Great. And again, we move on to the next score, which is the Barthel index of activities of daily living, and his score was 70 by 100, which is a moderate dependence score. So we come to the fact that he has obstruction, he has mild anxiety, moderately severe depression, and he is a dependent, and he has moderately severe obstructive lower urinary tract symptoms. And for further, and we now interpret these things, and we realize that this gentleman has cognitive impairment, poor diabetes control, high risk, severe lower urinary tract symptom obstructions, and FRAC score is below threshold, so we did not act, but we still want to do a BMD because even though he is not having a high score above the threshold of action, but he still needs to be screened because of his diagnosis of diabetes and overweight, BMI being 28. Moderate dependence on activities of daily living. So he would at some point of time require help in his activities of daily living. And we want to give him support. We want to give him, the family, some support and emotional support to see what is there in the pipeline for as time progresses, and urology referral for severe lower urinary tract symptoms. And we can, in case the depression does not improve or symptoms do not improve with the cognitive therapy and psychotherapy, we must consider pharmacotherapy for him, and for that we must evaluate him because he's having moderately severe depression. So definitely pharmacotherapy has to be started, and in order to prevent further loss of bone or to contain the speed of bone loss, we must start him on calcium and vitamin D after we get a DEXA scan. The only precaution with a DEXA scan is that we must withhold calcium for 48 hours prior to ordering DEXA scan. Rehabilitation and occupational therapy for activities of daily living, and we must make his in a home environment fall free to enable a smooth life for him. So we can remove the rugs, loose rugs. We can give him grab handles in the toilet, and we can make transitions between different floor levels easier. And we can tell the family to actually work together. So we know what we have done, and now the son comes. Son says, okay, thank you very much for the papa, but what about how do I fare? Because my fathers have been sick. So see, we say in this scenario that he was concerned about his own risk for diabetes, who is seeking your advice too. So what we do is we screen him with a Indian diabetes risk score developed by the Madras Diabetes Foundation by Dr. V. Mohan, and we see that his score is 70. Now this is a relatively higher score. So total score of 40, high because of the family. It has certain 4 or 5 points that need to be checked, and it requires confirmatory glucose assessments. This score of 70 requires confirmatory glucose assessment, lifestyle changes, and consistent monitoring. And because mental health is again going to be taken up as a separate thing on coming Tuesday, I saw a message. So I could not in this limited time cover most of the other things, but this would give you a brief snippet of the depression, its causes, its screening tools, its risks, and its possible treatments. And this was put on the AFPI chat groups by somebody. So I just taken it from there, and I would like to draw your attention to the fact that for those of you who can attend, please do make sure that you register yourself for the July AFPCon Delhi, because we will be conducting workshops on the 5th and the 6th, and see some of it will be there. Thank you very much for your kind attention and the time.
Thank you very much, Dr. Hemant. A very lucid presentation, especially the slides were very good. And you began with what I call it as the triple diagnosis, the physical, social, psychological, or including the biochemical, to give a holistic approach. And then you zoomed into the scores, which were done.